All right, I'd like to talk to you about CCBs, also known as calcium channel blockers. Examples of drugs in this class would be Norvasc, Cardiazem, Verapamil, amlodipine, Procardia XL. There are several more, but those are definitely the ones that I see used most frequently. These drugs have a lot of therapeutic effects or therapeutic uses, so you really want to know what you're giving it for. It can be as an anti-anginal. It can be given for both chronic stable angina versus unstable angina. Again, only certain drugs in this class are used for each of those. It's also an antidithyrismic and also an antihypertensive drug. So it's important to know what you need to check before this drug is administered. So you want either yourself or your patient to know to check the blood pressure and heart rate, partly because of what its intended effects are. So if it's an antihypertensive drug, if I'm giving it for your high blood pressure, if your blood pressure is 80 over 60, I don't want to give you something that's going to lower your blood pressure. Even if I'm not giving it for high blood pressure. Let's say I'm giving you it for your chronic stable angina. If one of the side effects is it can cause uh, hypotension, I need to make sure you're not currently in a hypotensive state. Same reason why I need to check the heart rate, because since you can see there, it's all negatives. It's negative ionotropic, negative chronotropic, and negative dromotropic effects. Means that, again, remember, negative ionotropic means it reduces the force of the myocardial contraction, so it decreases how hard your heart has to work. It's going to decrease it's got the negative chronotropic, which means it's going to slow down electrical conduction, so help with some of those dysrhythmias. And then lastly, it's got the negative dromotropic, which means it's going to decrease the heart rate. So if it has negative dromotropic effects, I better know what your heart rate is beforehand, because I don't want to cause you to go into bradycardia. This drug works by causing vasodilation at the coronary arteries when we're talking about anti-anginal. It also does it in the arterioles, which is going to, again, lower the blood pressure and the cardiac workload. There are lots of things that we need to monitor for in this patient. So, for example, we need to look for reflex tachycardia. So when we're evaluating, we need to go back and look and see how is this patient's heart rate doing. A big one we need to monitor for is actually, and I didn't write it down there, but is about signs of heart failure. So edema and weight gain are big ones that we want to be watching for, especially peripheral edema. That's one of the most common adverse effects. So we're going to monitor daily weights. We're going to look at their I's and O's, and then the signs and symptoms of heart failure, like dyspnea, crackles, weight gain. We're also going to want to be monitoring for if they're having any bleeding gums. Common side effects can be flushed skin and headaches, just like we talked about with nitro as the anti-anginal. When it's causing that vasodilation, it can end up causing some flushing of the skin as well as headaches. So some patient education we're going to want to do is when to hold the drug and call the provider. Another big one is if we're using this as an anti-anginal, we want them to keep an angina diary and include the frequency and severity of their angina attacks, because I want to know is when I go to evaluate, is the number of attacks or the severity of attacks going down? Is it staying the same? Because then this drug's not the right drug or the right dose, for example. Another thing is I'm going to, since one of the things is a risk factor for this drug is orthostatic hypotension, I'm going to make sure that I do education about getting up slowly to help decrease dizziness and falls, even changing positions, not even just getting up from chair to walking. Also, that if this is has a risk for orthostatic or hypotension, then things like when you're out in hot weather, your risk is actually going to increase. Another one you can see there, since the bleeding gums is an issue, we're going to want them to make sure they're doing good dental hygiene. And then we're also going to need to educate them about some of the common food-drug interactions. As grapefruit's a big one because it does work for that P450 system, and then also alcohol as well. So how can we know if this drug is effective? Well, we're going to see a decrease. And again, it depends on what is the reason why this patient is taking the CCB. If they're taking it as an anti-anginal, then we should see a decrease in the frequency and number of anginal attacks. Also should see a decreased need for nitrate therapy because remember that's like their rescue. We should see some increased activity tolerance. Now, if they're taking it as an antidysrhythmic, when we look at that EKG, we should see, or telemetry, we should be seeing less, for example, they're throwing less uh, dysrhythmia. I'm not going to get into the specifics. You don't need to know the specific kinds. And then if it's used as an anti-hypertensive drug, which we will talk about further, then we would be looking for that blood pressure to be back into the normal range. The last thing I wanted to tell you about with these CCBs is they have a lot of random uses. So as you can see, there's already several up here, and these are really only the very common ones. There's also things like Nimetop is actually used for subarachnoid hemorrhage patients. We'll see. I see that commonly. Procardia can be used during hypertensive crisis, hiccups, and to help prevent migraines. All right, and then the other class of drugs we're going to talk about this today is the beta blockers, and the examples of those would be like the atenolol, the metoprolol. Same with the CCBs. You need to be careful about if they're extended release or not. So there are some CCBs as well as these beta blockers like metoprolol can come metoprolol XL. So you know that when it's XL or extended release or SR, we cannot crush or chew that anymore. The beta blockers are going to be used for their cardioprotective effects. We like to use them in post-MI patients to decrease the stimulation of the cardiac tissue. We can even use it to prevent future MIs, as well as help with high blood pressure, again, the chest pain, the dysrhythmia, especially tachyarrhythmia, so high heart rate, and then also heart failure. So you definitely want to be assessing what is your patient's blood pressure and pulse. You want to make sure your patient knows how to do these. Once it becomes stable out in the community, every single time before they take their beta blocker, they should be checking their pulse. But actually, if the blood pressure is stable, they can even go down to only having to check the blood pressure weekly. But always that pulse every single time, whether they take it daily or BID or more frequently, they need to every time check that pulse. They also need to you need to make sure they know, again, when do they hold and call the provider. So typically we say less than 50 for heart rate for beta blockers. Obviously, if you get an order otherwise, I've also seen doctors' orders for less than a heart rate of less than 60 to hold this drug. If you do not have hold parameters, you would want to, again, hold that medication, talk to the provider, and then determine, is that when in doubt, always call them. The other thing here I wanted to talk about is things to monitor for. So again, same thing with the CCBs. We need to monitor for those signs and symptoms of heart failure, which once again are like shortness of breath, edema, weight gain, crackles. So how do we monitor for some of those things? Well, some of those are subjective, but other ones, if we're worried about weight gain, we're going to be doing daily weights. We also, again, this drug can cause orthostatic hypotension. So we better be checking someone's orthostatic blood pressures as well as doing patient education about the risks for orthostatic blood hypotension. So they need to get up slowly to avoid dizziness and fainting and falling. Now, one thing to remember with the beta blockers to help you remember is we do have beta receptors in our heart and our lungs. The way I remember is your beta, you have one heart and two lungs. So the beta 1 receptors are in the heart, the beta 2 receptors are in the lungs. So knowing this, again, if the drug is non-selective, which for example metoprolol is non-selective, it's going to be, for example, contraindicated in patients with acute bronchospasm. And actually we're going to say we want to use cautiously in any patient with lung disease. It's also be contraindicated with anybody who's got a bradyarrhythmia. So if the patient has a low heart rate, so their heart rate's 35, I'm definitely not giving this medication because it's only going to make that worse. Some other things that we need to do with patient education as well as being aware of is, for example, this drug can mask hypoglycemia. Therefore, we need to use cautiously in patients with diabetes. So we will need to teach those patients that they need to check their blood glucose even without signs and symptoms of hypoglycemia because it may not they will not usually have those signs and symptoms of it. So they need to, no matter what, be checking their blood sugars. Another big thing to educate your patient about is why they cannot stop this medication abruptly. Like, this is not the drug that you are short on money, so you don't, you refill some of your drugs, but this one you do not refill. You cannot abruptly stop this medication. We need to slowly titrate down over 1 to 2 weeks. Because what can happen if a patient's been taking this drug, let's say for 6 months, and suddenly like they lose their job, they lose their insurance, and they can't afford this medication, what can happen? It can be life threatening. We can get life threatening arrhythmias. They can end up having rebound hypertension, and it can cause an MI or heart attack. Another thing to also be aware of, especially is if your patient is on digoxin. It can have the additive effects with digoxin, so they're going to have increased risk for bradycardia and myocardial depression. So how, again, now back to evaluation, I've kind of been going through the entire nursing process here. How can you evaluate, or how do you know what to evaluate if this drug is effective, if it's doing its intended use? Again, it depends on what are you giving it for. That's why it's very important to know why you're giving this medication, because if you are like, oh yeah, beta blockers are for chest pain, and you tell, oh, this is going to help you prevent having chest pain, and the patient's like, I've never had chest pain in my life, your patient's going to be very confused, as well as decreasing their trust in you. So, if you're giving this at further hypertension, you would evaluate the effectiveness based on, does it decrease the blood pressure? If it's for the angina pectoris or chest pain, do we see a decrease in anginal attacks as well as the severity of those attacks? If you're giving it for the tachyarrhythmia, do we see that now being controlled? If you're giving it for MI prevention, are we seeing that the patient has not had an additional heart attack since being put on this medication? Please feel free to email me with any questions. Good luck.